Thank you, Vikrant. And moving ahead to a different topic altogether. So I have given a topic of steatotic liver diseases, histopathological aspects. So only disclosure I have here, I am not a histopathologist. So what I'll do from a clinical point of view, what does the histopathology of steatotic liver diseases or MASLD or whatever you want to call it, I'll give an overview on that only. So let me start with the thing that all fat in liver is not MASLD. This is especially true for pediatricians because we know we want to exclude the genetic liver disorder. So every ultrasound which carries a fatty liver report does not mean that it is MASLD. Especially for us, you can have genetic metabolic liver disorders, medications, dietary factors, infections, and this is the important group which I would say adult hepatologists usually miss. And this has been proven in studies that if you look at larger pediatric hepatology units, only about 50% fit into your classical MASLD. Almost 40% are not MASLD, they are MLDs. These are ultrasound showing fatty liver with or without biopsy being proven. So I'll go through some cases. These are real life cases, published cases. First two cases are from our department, rest of the two cases I highlighted because these are adult patients. So if you see younger patients coming with upper abdominal distension, hepatomegaly ultrasound showing fatty liver, but if you look at these two cases, adolescent girl and a 28-year-old female, they have been carrying a diagnosis of lean MASLD and NASH for 2 years and 10 years. Before somebody decided to take a detailed history in which she had a history of neurological involvement 2 years back and she had a history of recurrent episodes of low energy, lethargy, decreased appetite intermittently. When somebody started to investigate, they could find a mitochondrial hepatopathy or a FAOD related gene defects into these two cases. So they were labeled as lean MASLD or MASH, but subsequently we could diagnose them as mitochondrial hepatopathy and FAOD after so many years of lean diagnosis. If you look at their biopsies, they all look the same, don't they? All look steatotic and you cannot differentiate between these two. I'll give you another case, adolescent case, which adult hepatologists would also see. A 14-year-old guy who is coming with recurrent episodes of pancreatitis, is lean MASLD, has acanthosis, insulin resistance and grade 3 fatty liver. Was subsequently diagnosed to have familial lipodystrophy, but look at the biopsy. He had 11 episodes of pancreatitis second to this genetic disorder. So the message here is that, first message is that if you see a biopsy or ultrasound showing fatty liver, it does not always mean MASLD. There are always pitfalls and fallacies. If you start evaluating without a clinical concept, irrespective of the age, whether it is a child or an adult, you can have a misleading interpretation and it is applicable to both of these, especially if you label a patient as lean MASLD or MASH. So I cannot go much into the detail of pathophysiology of MASLD, but only a couple of slides. So once you start ingesting your lipids, it gets packed into chylomicrons, goes into the capillaries, this lipoprotein lipase acts on these chylomicrons. The fat which is released goes inside through apolipoprotein E, and this cholesterol and free fatty acid either undergo de novo lipogenesis because liver wants to utilize this fat, or it will try to excrete and remove the fat from the liver through VLDL, which subsequently converts from VLDL to intermittent density or low density lipoprotein, which can either go back into the liver through these LDL receptors, or it can subsequently get metabolized in adipose tissue and bones. So there are only two ways you can have fatty liver, and this has to be a balance between the lipid acquisition and the lipid disposal. So if you take a very high carb diet through these carbohydrate responsive element binding protein or sterol responsive element binding protein, which are master transcription factors, it can lead to increased de novo lipogenesis. That means the liver is trying to convert this carbohydrate back into the fat. Or if you have insulin resistance or increased lipolysis in the adipose tissue, which increases the free fatty acid efflux into the liver, this causes your free fatty acid accumulation. And you should understand that free fatty acid are toxic, but liver wants to convert them into an inert substance which is a triglyceride. So what happens to this triglyceride? Either it can get oxidized to fatty acid oxidation, which usually happens in mitochondria, but when you have lipotoxicity because of excessive triglyceride, it can convert this oxidation to gamma or omega oxidation, which happens in peroxisomes and lysosomes. But if you have a defect here, that these are not getting oxidized or these are not getting excreted through this VLDL due to impaired efflux or utilization, this causes hepatic steatosis. So, I will go brief into the histopathology, that is my main topic. And if you look at the MASLD or MAFLD, whatever you want to call it, there are only 3 categories. One is steatosis, one is activity in the form of ballooning degeneration, and fibrosis. I will focus most on steatosis and predominantly of ballooning degeneration, because that is the most important prognostic factor. I will not go into the detail of fibrosis because it is very well known. So, these are all the beautiful diagrams which have been provided by Department of Pathology. You have pan-acinous steatosis, you have zone 1 predominant steatosis, you have lobular inflammation, significant portal inflammation, ballooning, and predominantly type 2 or zone 1 predominant NASH. So, previous terms that were used to define steatosis were macrovascular and microvascular steatosis. We have moved slightly away from these definitions. What we currently use are a large droplet type macrovascular steatosis. That means you have a large steatotic vacuole inside the liver, which is larger than the surrounding non-steatotic hepatocyte, and previous terms they used to use more than 200 micrometer per square. And the second term, they have differentiated macrovascular into a small droplet type. So, there is a large droplet and there are smaller droplets, or you have a microvascular steatosis in which you cannot see the droplets per se, but there is a foamy cytoplasm and the size is roughly less than 2 micron per meter square. The second important component is hepatocellular ballooning. So, what is ballooning per se? Ballooning means the hepatocyte gets enlarged. There is a rarefied cytoplasm with a larger hyperchromatic nuclei and a larger nucleolus, which is secondary to keratin degradation. So, if you see the HE, there is a large hepatocyte rarified cytoplasm, and you should see that this bluish one is the cytokeratin. This is the cytoskeletal component of your hepatocyte. Usually it should be a uniform appearance. Everything should be brown, entire cell. But what you see here is that the cytokeratin is getting accumulated or aggregated to smaller size. And secondarily, if you use the ubiquitin, which is a ER stress marker, you will see these are what are typically, these are the Mallory-Dank bodies, which secondary to keratin degradation, this happens. And the second important component is sonic hedgehog, which is named by the video game character. What this tells you is that normally the hepatocyte should not show any sonic hedgehog. Hedgehog is nothing but a marker of ER stress, which subsequently happens when the hepatocyte gets ballooned and it causes a diffuse hepatocellular staining. So, this is pathological. So, why is it important? Because studies have been done, they have shown that if you give a marker like tunicamycin, which is a ER stress inducer, it will cause your cytoskeletal, this is K1819, this is normal. If you give it, the cytoskeletal will break down, K18 and 8/18 will go down, ubiquitin, which is a stress marker, will start increasing, your sonic hedgehog and Indian hedgehog both will start increasing. So, what it does is, sonic hedgehog acts in a paracrine manner. ER stress is induced, cytoskeletal gets broken down, starts aggregating in the form of ubiquitin, gets aggregated by p-Fis62, and then causes a release of sonic hedgehog, which acts in a paracrine manner around the hepatocyte, not in the hepatocyte per se, and subsequently causes alpha SMA or activates the myofibroblast, which is surrounding the hepatocyte, and subsequently causes fibrosis. So, therefore, ballooning has been correlated with fibrosis per se, and you can see the as the number of sonic hedgehog positive hepatocyte go up, the ballooning and the fibrosis starts progressing. And this has been shown. This is the study from the Pivens trial, if you remember, from NEJM in 2010, and they have shown that the sonic hedgehog pre-treatment and post-treatment with vitamin E only. They have shown that these are 59 cases they could evaluate, 30 and 29 on both sides, and they have shown that if you give treatment, the sonic hedgehog levels or the staining goes down, and K18 and the cytokeratin markers which were aggregated now start becoming diffuse or becoming normalized over the time. And the glytooths, a progenitor marker like SOX9 or alpha SMA, their levels go down once you start treating them. And also HSP27, the heat shock protein 27, it is a antioxidant marker. Body feels stress, it produces HSP27 and helps prevent the cytoskeletal, prevent the oxidant stress. But if you see the patients who have a significant ballooning, what they show you that the HSP27 immunostaining goes down. So these cells have been called as something like undead cells. So what happens is, if you have a lipotoxic insult, if it is lethal, which is usually not there in mast cell, you causes apoptosis. But if it's sublethal, that means the cells are not being died, they become ballooned with mammary bodies, and they may, or subsequently they may release these extracellular vesicles. Maybe Dr. Sukriti would be able to explain it well. So these extracellular vesicles may act as dams, may cause macrophage activation and infiltration, may cause endothelial migration, and may even cause, depending on the specific type of extracellular vesicles, can cause the myofibroblast or HSC proliferation, leading to fibrosis. So before we go ahead, before I explain the ILBS experience, I'll just briefly go to the scoring systems, these are important for use in mast cell. Starting from 1999, when Dr. Lisa M. Brent present these data from University St. Louis, the second scoring system that came up was the NASH CRN, or Clinical Research Network. They use steatosis, lobular inflammation and balloon degeneration. The entire term they call it as NAFLD activity score or NASH score, and more than 5 was labeled as NASH. But these had issues because they were never designated to diagnose NASH. So predominantly we use it not to diagnose NASH per se, but to track the severity and assess treatment response, and this is the most common scoring system that they use. The second came by Professor Bedossa from France. This was a single center study to begin with. Then they validated using this fatty liver inhibition progression by 8 European centers using 12 hypotheses. So the terminologies remain the same, the steatosis, but they differed that activity would include only lobular inflammation and balloon degeneration. They are almost the same, some bearing variations that the number of how would they score balloon degeneration or lobular inflammation, but the parameters remain the same. And what the best thing about this FLIP algorithm or SAF algorithm is that it does not categorize borderline NASH or NASH. It gives you either it is NASH or not NASH. They are absolutely clear. So, and the third parameter, which is used in pediatric populations but not very well validated, this came from 2 centers, one from I think Hopkins and one from in France, and what they gave is that they included portal inflammation, because they say that children have less classical ballooning and more portal inflammation, and they came up with this mathematical score. But what we use here, we give you both at ILBS, we give you a NASH score and we give you SAF score, so you can use both of them for your practice. So I'll briefly go to the ILBS experience, thanks to the Department of Pathology. What we did, we wanted to categorize, because there is limited data on overall the pediatric aspect of histopathology of mast cell. So give you a classical histopathological spectrum and also evaluate the role of non-invasive modalities with histology. So over the years, we had 136 biopsy proven mast cell. After excluding those we could not reevaluate on pathology. We looked at all these parameters, looked at the inter-observer agreement, and also tried to predict the fibrosis predictors. So let me start. We used 2 pathologists, 2 independent pathologists. They evaluate these slides separately, and both of them came with a very good agreement, inter-observer agreement. The steatosis grade, predominantly 2/3 had higher grade of steatosis, and predominantly it was a zone 3 central. That is not unlike the previous data that we had seen, that pediatric population is zone 1 or portal predominant. The surprising thing was that almost 10% had advanced fibrosis and almost 4% had cirrhosis in pediatric population. If you compare it with the previous literature, this proportion of cirrhosis varies from 2 to 4%, and the advanced fibrosis, which we call it as F3, F4, varies from almost 1/5 of your overall patients. So these are sicker patients, you cannot neglect, but there is always a referral bias because we are seeing the more sicker or mast cell patients. There was significant ballooning, portal inflammation and lobular inflammation was also seen in a significant proportion of subjects, and Mallory-Denk bodies were only seen in 17%. So, if you look at all these three parameters, the best modality to diagnose MASH was the SAF score, because only 50, if you use the NAS CRN and give a cutoff of more than equal to 5, only 50.7% could qualify as MASH. So, SAF score still gave us the best term. And there is a controversy which I was alluding to earlier. Previous literature, starting from Professor Jeffrey Schimmer in 2005, they had tried to differentiate pediatric, that is the type 2 NASH versus the adult type, which is type 1. But what we found is that predominantly it was a mix of overlap. We had almost type 2 was only 1.5%. We predominantly had a type 1 or an adult type of this. So, what is an adult type? What they say, it is a zone 3 predominant changes. Steatosis would be there would be a perisinusoidal fibrosis or the chicken wire fibrosis they say, and the ballooning degeneration is higher. But in children, what the Jeffrey Schimmer had shown that almost 60% had a predominant. But this literature did not go beyond early 2010. Some studies tried to overlap it, but now the latest studies have not tried to differentiate type 1 and type 2. They only tell you what is the exact finding. And this is important because we try to evaluate whether the cap that you see on fibroscan or the LSM that you see on your fibroscan, does it correlate with steatosis on biopsy and fibrosis on biopsy. So, there was poor correlation between cap and steatosis, but a good correlation with LSM and fibrosis. What does it mean? On ordinary logistic regression, though there is a poor correlation, but there is a trend that as the cap goes high, your steatosis grade on biopsy will also go higher. Also, as your LSM goes higher, there is a 29 increasing odds of higher histological fibrosis grade. I will show it in the form of a diagram. There is no good correlation between cap and steatosis on biopsy. You see the biopsy, even in stage grade 1 steatosis on biopsy, your cap values 1, 2, 3 remain almost the same. There is an increasing correlation between LSM, but this is okay. And this is not our only finding. And almost I will show you that not even your area underscore, we could try and come up with the cutoffs, but the area underscores were not very good. It should be at least more than 0.8, something like that. And this is not our only finding. If you see the largest study from NAS CRN group in pediatric age group, they could also find that there is no correlation between your cap and your LSM that you find on fibrosis vis-a-vis your biopsy. Look at there, they all could find even with the stage 1 steatosis, your cap in stage 1, stage 2, stage 3 looks almost the same. So, you cannot differentiate. People have tried to give a cutoff, I will show the cutoffs also, but not very helpful. And even their fibrosis grading on fibroscan versus your steatosis, not very good area under curves. And previous cutoffs people had tried to in pediatric age groups have given a cutoff for diagnosing steatosis roughly varying from 225 to 260, but as you can see here, it is not very helpful. And just as a predictor of fibrosis, higher AST levels and portal inflammation were the two only independent factors. So, last concluding slides, the way forward is always AI, machine learning, digital pathology. So, what is digital pathology per se? What you do is you take try and convert the pathological slides that you have into whole slide images. You take so that your resolution becomes higher, you digitize them. It is like looking at a Google map on a biopsy. You know where there is the hepatocyte, where is the fibrosis, where is everything. And what it tells you, this is the classical picture that you see, but if you try and do it using machine learning and AI, it will give you something like this. Green one is the fibrosis, blue is the ballooning, and purple is the inflammation. It gives you a more, I will say a more representative picture, more easier to see. Also, it can tell you that if you look at the mesentericum, this is how it will give you this. So, I will give you an example. It will say, if pathologist would say that the fibrosis is stage 1, say 0 to 5 to 33%, but this would quantify it as, it would say 22.5%. If you see fibrosis, we would say stage 1 or stage 2, it would say stage 1.7 using the collagen proportionate area. So, it can tell you that if you see this study, they have shown that for a one stage improvement that we classically use in all the clinical trials, the numbers are lesser, But if you try and use the delta fibrosis score, which is one of the scores that you use, you can see a very significant improvement, though it is very, very sensitive to change. It does not has to categorize into stage 1, stage 2, stage 3. It can go in between those stages. It can have very significant or better intra-observer or inter-observer agreement. It is not subjective. And the second important is second generation microscopy, harmonic biopsies or two plasma, two photon excitation fluorescence microscopy. These are just second and third generation microscopies. You look at these pictures, they will show you pictures like this on harmonic biopsies from HE, Mason's diagram. This is how they tell you. And what they can quantify here is that if you look at the biopsies, these are your run of the mill biopsies, but if you use these harmonic or second or third generation biopsies, it can quantify. These are Q fibrosis, Q fibs machine learning scores, which can quantify that your levels have gone down from 4.5 to 3.2, much more sensitive and less subjective. So my take home messages is clinical context and pathology are key to your interpretation. And the future lies with the digital pathology, machine learning and second generation microscopy, as is in any other field. And to acknowledge Professor Archana ma'am and Department of Hepatology, before I end, I would highlight that this work would not have been able to be finished barring the help of Dr. Ashray Patel and Dr. Megha Bansal. So thank you again, and to all the faculty of the departments. Thank you.